Now the next lecture is by Dr. Sudhir Warrier. He will be speaking on the carpal instabilities. Dr. Warrier has been trained with Dr. B.B. Jeshi for 9 years. He worked with Dr. Tarapurwala and Dr. Gawande during his residency. He did his MS Orthopedics from Grand Medical College, 1987. Had fellowships in Korea, Japan, Hong Kong. Recently practicing at Lilavati, Lord Clinic, Hinduja, and SportsMed in Mumbai. And recently he has been faculty for the first AO Trauma Masters course, Hand and Wrist at Davos. Welcome, sir.
At the outset, I'd like to congratulate Dr. Bhandari, Vishwas, Auchin, Rajesh, Pushpendra, Ashok, and Vivek for even thinking up something like this. I'm sure your hearts are filled with contentment when you look back and see how many people responded to your idea. The good thing that you did was to try and focus attention towards one particular thing rather than spread it out thinly and make it one of those superficial meetings. So you will see happiness on this side also, because we have more than 6 minutes to talk. Otherwise, we are given 6 to 8 minutes to explain something which we just cannot do. And last night we were discussing about how poor a teacher I have been over the years, that I have not been able to convey so many things to during my lectures. But I have one complaint to Vishwas. I don't see him here, and that is, ye kya topic de diya yaar? So this is a tough topic. For a long time I didn't understand what this was. For a long time I thought it wasn't essential for me to learn about it. But then I realized that more and more you look into it, you start understanding a little bit. Then you start relating things, and then you can begin to know what's going to happen before you can plan what you can do. So let's see whether we can understand wrist kinematics. When you see this first slide, you say, yaar chal, bathroom jate hain, pani pi ke aate hain, zara phone attend karke aata hoon, because these ligaments are not going to stay with me when I get out of this hall this afternoon. It's so difficult to remember the names of the bones itself. 60% of us in this room still look at the X-ray and say, Shri looks too pretty, acha ye PC form hoga. So now if I tell you there is a luno, this thing, that thing, PC form, ligament, to yaad hi nahi rehne wala hai. So forget it. Forget the names. We don't need the names. We've seen a little bit about the columnar concept of load transmission. Shailesh spoke quite eloquently on that. But even that ends up telling you this percentage, that this thing, and it really doesn't stay in your head. So let me try and make this a little simple. We look at these three as three little children. So that's the scaphoid, that's the lunate, and that's the triquetrum. So that's a very simple way of looking at it. They're three little children. Now think about this. When you grasp anything tightly or you lift a weight, the entire load of what you're lifting goes onto the metacarpals, from the metacarpals to the carpals, and these three fellows are there. These are three porters. Imagine them as Amitabh Bachchan in Coolie, carrying the load on his head. So these three fellows have to carry that load to the radius and ulna through the TFCC or whatever else is there in between, and transmit it evenly so that you don't have pain. So that's what these three are doing. Now if you just load them, they will split apart, because there's nothing that's holding them. Of course the ligaments are there, so the ligaments keep them together. So now you realize the importance of these ligaments, that they have to hold these fellows. So the scaphoid is holding the lunate is holding the triquetrum, and they're all very happy little children playing within the wrist, okay? And that's the oval concept of Lichtmann, which says that the distal row of the carpus is completely fixed for practical purposes to the metacarpals. Jaan छूट गई, सोचना नहीं है, वो हिलेंगे ही नहीं. So you have only three bones. The PC form is in the front, it doesn't really matter. It comes when you have triquetral problems. So you have now only three bones to concentrate on. Jitne ligaments hai, seekh jaunga main. It's not too much. Okay? So that's what's happening. So these are three children playing in the garden, swinging along from side to side with flexion and extension and holding hands. So that is the importance of understanding basically what's happening within the wrist. Now look at this, and you see from side to side movements what's happening. You see the distal row is not changing shape too much. We'll go over this once again if I can. No. So when you look at the scaphoid here, look at the scaphoid. What a massive change in the shape of the scaphoid. That is how much the ligaments are controlling it. Lunate thoda sa move ho raha hai, triquetrum up and down thoda move ho raha hai. So that is what's happening. Scaphoid flexes when you go into radial deviation. When you go into radial deviation, the scaphoid flexes. Now why does the scaphoid flex? Because you know that there is a slight volar tilt. So the scaphoid can't go up, because that umbrella on top is going to stop it from going up. So it has to come into flexion. On the radial side, you have the radial styloid. So it can't go out on that side. So it's prevented from the other side. So there's no space except down for the scaphoid. That's all you got to remember, and carpal instability becomes simple. Okay, so once you understand this, then we can go on to the next step. Now look at flexion extension. The lunate is practically not moving. Hardly any movement there, very little movement, but you see the rest of the bones, you see the scaphoid. Oh my God, there's so much movement in the scaphoid. Look at that once again. See the scaphoid moving. This here is the scaphoid. So you're seeing that move so much, and now you realize that there is more movement in the scaphoid when it flexes, not so much in the lunate, and a little bit in the triquetrum. So that's another point we made. All of this gives us 70 to 90 degrees of flexion and 70 to 80 degrees of dorsiflexion, 30 to 40 degrees of ulnar deviation, and about 20 degrees of radial deviation. So these are the movements that is happening at these joints. But remember, what you saw was a lot of this movement was occurring at the midcarpal joint and not at the radiocarpal joint. You saw the lunate is not moving too much. 60% of the flexion occurs at the midcarpal joint, not the radiocarpal joint, not at the wrist joint as we think about it. And 30% of the extension is occurring at the midcarpal joint. So now you understand that there is also a joint beyond the radiocarpal joint which gives you 60% of flexion, 30% of extension. What does that help you with? It helps you very simply when you start rehabilitating a post-distal radius fracture patient. You know the radiocarpal joint is going to be painful because the radius is involved, but the midcarpal joint is not involved. So start with the midcarpal range. It is going to be pain-free. It will give you 60% extension. It will give you 30% flexion. It is the reason why you get good results in distal radius intra-articular fractures with a step, because the movement is not occurring at the radiocarpal joint, it's occurring distal to that. So if you maintain that and don't allow that to get stiff early in the treatment, you're going to get good results. Your patient is going to be happy. So you need to understand this. Now what is this midcarpal range? Physiotherapist को लिख के भेज दो, please start midcarpal range. Physiotherapist बोलेगा ठीक है ऐसा करो and wax bath में डाल दो. Everything comes back with wax bath. So the midcarpal range is a wonderful range of movements. If you play darts, have you seen them playing darts? You stand like that and you throw the dart like this. So that is entire movement occurring at the midcarpal range alone, which is radial deviation and dorsiflexion to palmar flexion and ulnar deviation. So this movement is the midcarpal range. It requires so much accuracy that it's a wonderfully controlled joint. So that can start early in the rehabilitation. So now we know that the wrist is constrained by so many ligaments. We've come back to these three children. Incidentally, some children are borrowed, some are mine, or maybe all are mine. I work very hard, you know. But these three children also, if you remember and you look at this, show you the sizes of the bones that are there in the wrist. The scaphoid is the biggest, longest bone. The lunate is a smaller bone and the triquetrum is a chotu. Now the triquetrum, whenever you have any problems, the triquetrum, you must remember, is a tiny small bone. Okay. Suppose there is a scapholunate dissociation, scaphoid and lunate ligaments have torn, they have gone apart. What happens? You know the scaphoid has no place to go except down. So the scaphoid will flex. But what happens to the lunate and triquetrum? You know, when you walk with a small child in the park, the child has to always look up to you. Also remember, the child always wants to show itself as a big person. Child always wants to look up and become bigger and become one of those counted as one of the big fellows. So it's always going to look up. So remember that scaphoid has no place to go but down, and the triquetrum always wants to grow up and become big and looks up to the elders. Therefore, it's going to go into extension. That's it. So that's exactly what happens when the scapholunate dissociation occurs. Scaphoid goes down. Triquetrum says, come lunate, come with me, we are looking up. And that's what you get, a DISI deformity. Extremely simple to understand. And that's what you start seeing when you see a scapholunate dissociation. You will see a DISI deformity occurring there. Suppose the same injury occurs on the other side of the lunate. The scaphoid still has no place to go. The triquetrum is not holding this row. So the scaphoid says, chal lunate, come with me, because we are tied up together, and it goes into flexion. And the triquetrum is the shana, little child who's trying to grow up, so it will go into extension. And you will get this deformity occurring, which is called a VISI deformity. Now what is DISI and VISI? It basically means the lunate looks up or it looks down. And the lunate will look up or down depending upon whether the scaphoid is holding hands with it or the triquetrum is holding hands with it. Fairly simple to understand so far. And that's what you will see in a VISI deformity. Okay? It's difficult to identify a VISI deformity on an X-ray. So therefore you need secondary corroborative evidence or an MRI to tell you this. Now we come to the next stage. Now we understand what's happening within the wrist. We need to understand what's happening in instabilities. There are 4 different types of instabilities. They have different acronyms and names. But again, it's simple if you understand the basics. One is carpal instability dissociative. There are various classifications. You see an author and he's described a different way of describing wrist instabilities. And it's so difficult to understand that I stick to one and I try and relate everything to this one so that I can understand it much better. Now, what is carpal instability dissociative? Which means within one row. So we know the scaphoid, lunate and triquetrum are in one row. If scapholunate dissociation is there, it is a CID. And that's what you will see. These 2 ligaments, if they are torn, then you can get a problem. Okay? So the first and the commonest carpal instability is the scapholunate instability, where you will find tenderness at the scapholunate joint. Now where is the scapholunate joint? The scapholunate joint is easily palpated just beneath the Lister's tubercle. So if you palpate your Lister's tubercle and you just palpate distal to that down into the wrist, that is the point of tenderness for scapholunate disabilities. Okay, so whenever there is a dissociation, you will get tenderness there. A little to the radial side, it will be scaphoid tenderness. A little to the ulnar side, it will be lunate tenderness. So then you look at Kienbock's, or you look at Preser's disease, or you look at scaphoid non-unions or scaphoid fractures. But if it's right beneath the scapholunate, beneath the Lister's tubercle, that is where you will find it. The second thing is a Watson's test. All of these tests are very, very difficult to understand when you get it all together, because I doubt if any one of you has ever bothered to read, or many of you have bothered to read through whatever is written about wrist instability. Even today, I don't read a full chapter together. I read what I want, I retain what I want, and I don't read the whole chapter because it's so confusing and there's so much of information, 80% of which is complete nonsense. Complete nonsense. And because they cannot sift through the nonsense and give you nectar, they have written it all again. So whenever I write a chapter, I'm going to bring it all back in and I'll say, I've covered all of these things, and then I'll give what I think. So therefore, it's very difficult to understand carpal instabilities. So don't learn all of these tests, just understand the principle of this test. Now the principle of this test is based on what we saw with the scaphoid. The scaphoid is going to flex. So you stop the scaphoid from flexing. Scaphoid and lunate have gone apart. You stop the scaphoid from flexing when you push the rest of the carpus onto it. You know that when the whole carpus comes into radial deviation, the scaphoid has to flex. Now suppose you don't allow it to flex and say, nahi, tu aage nahi jayega, tu wahin pe rukega. Scapholunate dissociation has occurred. If two train compartments have dissociated and there is still force happening between the two, one of them has to jump away from it. The scaphoid then jumps out of the dorsal side of the wrist, dorsal side of the radial rim. So what you do is you prevent the radius, the scaphoid from flexing. And how do you do that? You put pressure on the scaphoid tuberosity. अब ये कहाँ पर है साला? ये होगा कहीं पे. Feel your PC form right now and move your finger towards the radial side. The PC form on the radial side is your scaphoid tuberosity, which is the point of entry for a scaphoid screw. So my next lecture is becoming simplified now. So you stop it. So you rest the elbow, and I'll show you a visual of this. You rest the elbow and you press on the scaphoid tuberosity with the wrist in ulnar deviation. So now the scaphoid is in full extension, and from here on you start pushing the wrist into radial deviation. So now you're pushing the unstable scapholunate joint. The scaphoid cannot go down. It jumps out on the back. It gets a big clunk, and if you take an X-ray, which I'll show you, so this is how it's done. This is Abhay Narvekar's ward boy. He's not got any dissociation. So that's all you need to do. Just press down and move from ulnar deviation to radial deviation. And if you feel a lot of pain, and if you feel the clunk, you're lucky to diagnose this. And if you see this, you will understand that's the scaphoid, that's the radius, and it's looking good. When you do the Watson test, that's where it has jumped out. I'll go back so you can see it clearly. So now you understand, and you can see during the Watson test, my thumb is here holding the scaphoid tuberosity there. So it's pushed it out from the back. Such a simple thing to understand. So the Watson test is easy, and that's what you see. And that at that time, you see what's happened to the lunate? It's gone into the DISI. Now we understand this completely because we know what's happening inside. You can also just give traction, and because the scaphoid and the lunate are dissociated, you might find the arc of Gilula, which Dr. Samir Gupta just showed you, will be disrupted. So the arcs will not be smooth. The commonest sign is the Terry Thomas sign. The commonest sign to see is the Terry Thomas sign. But you sometimes need to provocate it. And this is what P.C. Ho was talking about in the morning's video, where he said sometimes you need to have a provocative test. That it's not obvious, you need to load it. The porter ke sar ke upar thoda sa boja laga do, so clench his fist. The moment he clenches the fist, there's a lot of force going. The scaphoid and lunate will split apart because the capitate tries to drive through. Just look how clear it is on that X-ray. So it drives through, pushes open this, and gives you the scapholunate in all its glory. And it looks like the front tooth is missing, which was what Terry Thomas, the comedian, had, and therefore it's called the Terry Thomas sign. The ring pole sign is when the scaphoid flexes, you can see a ring, and the tip of the pole, it's meant to be less than 7 millimeters. This is Western literature. This is literature when X-rays were very nice things to take, because in those days they took X-rays which were 100% true size. Today it's not. Today they're sitting in the radiology department and fooling around with X-rays and sending you complete nonsense at times. They'll send you small X-rays, they'll send you completely Adobe Photoshop type. They'll take away all the trabeculae and send you a completely osteoporotic X-ray. So be very, very careful about what you interpret on your digital X-rays. Here's a case where if you look at this, you realize that there is something in between the scaphoid and the lunate. So I couldn't understand what that was. I said maybe a bipartite scaphoid, maybe it looks nice and rounded, not a fresh fracture, etc., until we took a clenched fist. One of the things that led me to that was a scaphoid flexed. The scapholunate angle is gone, and you can see what this is, a complete disruption. Okay, So we saw this, I think Shailesh showed this procedure. It's called the modified Brunelli procedure, where you take half of the FCR, and if you see here, I've just put in the joysticks into the bones, into scaphoid and lunate, and I've corrected the extension of the scaphoid, and you find that the scapholunate joint falls back into place, and then you can pin it down, and then you can do the rest of the procedure, which is a little technically demanding procedure, where you need to get the half of the FCR across through the scaphoid, across the two bones. You need to anchor it with two small anchors if you have them. They cost about 12,000 rupees now. They used to cost about 6,000 some time back. And fix this with 1 or 2 K wires, and at 6 months you can see that this is well maintained, and the patient gets back almost all of his movements in his wrist. So next is carpal instability non-dissociative, which means now we know that if it's within one row, and I'm not going to the lunotriquetral one because it's a very rare condition. I barely have seen a few, so I don't think you need to worry too much about that. Then it is the instability between two rows, between the radius and the first carpal row, or between the first carpal row and the second carpal row. So that is one of those cases which I misdiagnosed, and I did a surgery, and you can see my anchors there, and you can see that it was basically a midcarpal subluxation. So it's between two rows, and I thought it was a CID, and it turned out to be a CIND. So there is a non-dissociative, means each row is intact by itself, but there is a subluxation between the two rows. So it's a very rare condition. And then there's one which says it's complex, where you can have both. So if you have a fracture of the distal radius and you have a scapholunate dissociation, then you're looking at that. Now quickly, I'm going to just, I have 5 more minutes, and I'm going to quickly get across this one other concept, rather than getting into details of each one of these. And that is the perilunate dislocations. That's such a common thing. Yeah. You must understand that all these ligaments that we did not speak about, and I didn't name a single ligament because I don't think it is very important to know the names of the ligament if you know what they're doing, and if you know how to treat that. I think that's more important than knowing the names, because when you open up, certainly you do not see them in such great detail. You have to know where it starts and where it ends, and suppose that what fibers you're seeing are those ligaments. They are not very clear to see when you open up. It's the volar 2 ligaments that are important, which hold the lunate together. All the other ligaments are also important, but these two fellows are, say, ligaments for life. They tell the lunate, till death does us apart, we are not going to separate. So these two ligaments hold on to the lunate. Very, very rarely with an avulsion injury or a injury that involves a lot of shearing, this may tear off. Now when you have a perilunate injury, it's often a polytraumatized patient who's lying in the ICU, has a chest injury, has a pelvic injury, is bleeding from somewhere, has got intra-abdominal injuries or a head injury, and as soon as he comes in, he's in shock. So they have revived him and they've taken him to the ICU, and he's got a central line somewhere. He's got 2 IVs running in, lots of fluid. The IV went out, so they took another IV, and then they took a third IV, by which time they revived him, got his head injury corrected, got everything else corrected. And on day 14, he says, "Mera haath dukh raha hai." It is not easily identifiable because there are many other injuries that require your attention, and rightly so. So the patient is alive now, he's safe and good, and right now he complains of wrist pain. And you say, "Oh, this is because of the IV that went out, so take an X-ray please." When you take an X-ray, you'll see this. You say, "Hai, kuch to theek hai, radius acha lag raha hai, nothing else." All those lines, something is wrong, but I really don't know. So we need to understand how to look for what problem you're looking for. So you should know what problem you're looking for. So for me, again, when I look at those X-rays, I can't make out very much. It's a portable X-ray. It's not very clear, and I need to have something more to tell me. So here's how I look at it. For me, this looks like a cashew nut and a loudspeaker. Exactly like that, isn't it? So when you look at this, this looks like a cashew nut, and this looks like a loudspeaker. So you must see that the radius and the cashew nut and the loudspeaker are all in one line. And they are. Now, when you look at this, you can easily see the radius, you can see the cashew nut, and you can see the loudspeaker. for many of us, this may be the first time you're looking at these three things. Because we really don't bother. We are looking at the distal radius. If nothing is there, look at the scaphoid and thank you very much. Beyond that, we are not really looking. Beyond that, we are hoping that the CT or the MR will tell us. You don't need to worry. These things are very clear on these X-rays. So once you see this, you know that everything is all right if they are collinear. But if they are not collinear, as you can see now very clearly in the X-ray below, it tells you exactly what the problem is. So now you can easily identify what this is, because you look for something that you can identify. Look for the cashew nut, look for the loudspeaker. Okay? Now there are two terminologies that I'll have to complicate you with. One is the lesser arc injury, where the injury runs around the ligaments of the lunate alone, or the greater arc, where it involves some bone also. So it could be a trans-styloid, radial styloid, or a trans-scaphoid, if the scaphoid is fractured, or a trans-capitate, or a trans-triquetral perilunate dislocation, depending on which bone is injured. And that's what you look over here. You can easily see that the scaphoid is gone and the triquetrum is gone. So you can say a trans-scaphoid, trans-triquetral, perilunate dislocation, tells you it's a greater arc injury. It means more than one bone is involved. A lot of area of the wrist is involved, and therefore the results are not going to be 100% or normal. He's going to have a lot of problems. Okay? And you can see the scaphoid and the lunate and the capitate, or the cashew nut and the loudspeaker don't sit in each other. So now you can interpret this X-ray so much easier, because you're looking for things that you can easily identify. And finally, there is the carpal instability adaptive, which means basically this is because of an injury which has changed something away from the carpus but has had an effect on the carpus. So the carpus is trying to adapt. And adaptive instability occurs in distal radius malunions. As you can see here, there's a dorsal tilt in the radius. The lunate follows that. The rest of the wrist has to become straight. So therefore there is correction occurring at the lunocapitate joint, and that tells you that there is something wrong. They are not collinear. The lunate is looking up, but the capitate is looking straight. From the radius to the capitate, the line is straight, but the lunate is looking up. So there is something in between that has gone wrong. The adaptation is occurring in the ligaments, and when the patient, when you dorsiflex it, you find the correction and collinearity occurring. The moment you palmar flex it, the ligaments on the dorsum of the lunate and the capitate start getting stressed. Also, you start getting pain in the rim of the radius on the volar side, and therefore you can get pain on both sides in an adaptive problem. So you need to correct the radius to correct this. You cannot do anything in the carpus, because though it seems as though there is something wrong in the carpus, the problem is the radius. Alright? Here's a maluniting distal radius fracture, and you can see the wrist, hardly any supination, hardly any pronation, opened up from the dorsal side. Most of the injuries on the dorsal side, no point going from the volar side, very thin rim of bone on the volar side, little better shelf of bone on the dorsal side. So therefore went from the dorsal side, corrected that, all the carpus has fallen back into place, looking absolutely collinear, and therefore he should obviously get, he had a bilateral similar problem. I'm not going through all of that details. So that's the other this thing. We will not go into midcarpal instability, because it's again one of those very, very rare conditions. Suffice it for me to say that if you have understood what happens to the scaphoid, if you have understood that these three children in the park are playing with their hands held, and that when the scaphoid leaves the hand of the lunate, the scaphoid can only go down, and when the lunate and the triquetrum have left hands, the triquetrum will only go up, DISI and VISI should fall into your mind very, very easily. Once you identify that, treatment of this is a little complex, but we've seen that those operations are successful and they are treatable. Thank you very much for your attention.
Thank you very much, sir. I think this has been really difficult for us from our first MBBS time to learn the carpal bones. So every medical college has had some tricks. So in my first MBBS, the carpal bones was SLTP, Suresh Lal Tange Pasar, Teri Tange Chikni hai. So this, so you have made this complex problem looks so simple and
Probably
easy.
that is what attracted me towards this topic, I suppose.
Yeah.
उसके टांगे जरा बराबर से देख लूं.
Thank you, sir. We
Thank you
shall
very
have a
much.
discussion later, sir.